Hey everyone, thank you for joining our webinar. Our topic tonight is diving into a little bit about what to do if you didn't match, which, um, it's perfectly normal to have a whole array of emotions towards. And our goal tonight is to help you unpack that and also help you figure out the next steps going forward about what to do from here. And a big part of that is navigating step three. And so, at this point, you've gotten through step one and step two, and now it's a matter of, maybe you can utilize, and very much so you can utilize step three in your preparation for it and your score from it to move forward and ultimately get that residency position. My name is Mike Stevens. I am a PGY2 dermatology resident. And I've been with MSD for about 2.5 years. I love working with students with really every step of the process from step one, step two, step three, residency applications. I'm thrilled tonight to be joined by Roshan. Roshan, I'll let you introduce yourself.
Sure. So my name's Roshan. I'm also a PGY2. I'm in ophthalmology, but I've always kind of enjoyed the studying of step one, step two, step three. So I've also been a tutor for about 2 years. And I'm hoping that, me and Mike can both give you guys some insights just from our personal experience, experience with our friends, experience with colleagues, of what to do in this kind of difficult situation, but one that really doesn't have to define your medical career.
Absolutely. All right. So kind of our plan for tonight is again, just to talk through kind of the next steps going forward. And now that you have this time, what are the things that you can do to optimize your use of it to prepare yourself for success? And then we'll shift gears a little bit into the step three component of the evening, talk a little bit about an overview of the exam, what to expect, and how to navigate studying for the test, scheduling the test. One unique aspect, of course, about step three is that it spans 2 days. And in addition to the multiple choice component, there are, of course, the CCS cases, which are a little bit of a nuance, a little bit of a unique aspect of this test specifically. And so we're going to spend a good chunk of time talking about how to approach those. And I think the most useful component of it will be our going through a couple of sample cases. And then, of course, my favorite part of all of these webinars is a Q&A session at the end. We'll do our best to, so, if you have questions that come up in real time, feel free at any point to drop those into the chat, and we'll do our best to address them as they arise. Anything we don't get to or anything you want to say for the end, we'll have a few minutes at the end to run through. And then just a little quick blurb about who we are at MSD. So obviously, we focus on one-to-one online tutoring, again, really at every step of the process for obviously you guys have taken the MCAT in step one, step two, but then even beyond, we do a lot with, of course, step three, and even now residency, the process through residency and taking your board exams, a long track record of success, and just incredible people who really love what they do, who've kind of figured out the best way to navigate going through medical training and want to pay that forward to help with the next group of trainees. If a listener tonight did not match, what are some suggestions or advice that you give to them about the next step forward?
Yeah, so the first day is, of course, you find out whether or not you matched, and then the next step is the SO process. But that's not where it all ends. And so there's still opportunities for unfilled positions, and there's a lot of different ways to go about this. So there is the NRMP list, which will list available residencies. There's a Find a Resident website and a Resident Swaps website as well. And we'll be trying to provide links to those as well, something that I would highly recommend at least perusing, and I'll be honest, yeah, these opportunities, they get fewer and fewer after SOAP, but that doesn't mean that people don't find residency spots even after SOAP. So just, if you're here, that means you're being proactive, you're really trying to, take charge of the situation. So this is just another step. And I think another thing is that in medicine, in my experience, and I think Mike would echo the same sentiments, and most people would, is that medicine is a very collegial field. And when it comes to people who are having a tough time, it's always important to, ask your mentors and other residents. In my experience, people are always willing to help one way or another. They may not be able to get you a spot, but they can offer you a lot of advice, a lot of insight. And even mentors can, they may not be able to make a phone call, but they can tell you how to go about, the process and what's worked for other residents that they've mentored in the past. And now, like, kind of some specific things to go about it. I think initially, right now, it's completely understandable to just have a feeling of either determination, disappointment, and that for the first week or two, that's perfectly reasonable. And now the next steps is, now that you're here, is what is going to what do you need in order to reapply? And for me, it all comes down to what were the weaknesses in your application. Was it limited U.S. clinical experience, low board scores, which I think is often a common factor, a lack of research, red flags in your application. You weren't necessarily, you were kind of like vacillating between whether or not you're going to apply this year. And I think there's a lot of factors, and a lot of them are unfortunately out of your control. But what is in your control is how to make a plan to address them. And I think it's really important that you sit down. Often I would recommend with a mentor, a residency advisor, with your respective med school, and find out what exactly were those deficiencies in their opinion, and what can you do to address them. And one thing in particular that I really want to point out is that residents go unmatched every year. So this is where I think people will be really willing to help. I personally had a friend who went unmatched, and he soaked into a preliminary year spot. And in between that process, he reached out to a lot of different people within the field that he was applying to and hoping to end up in, people who similarly had done a preliminary year, but he made sure to, exhaust all the avenues of people that he knew, or even people that were kind of friends of friends, but they were the ones who I feel like gave him a lot of insight and helped him have like a very targeted plan. And he ended up matching this year. And so I think that's something that he was very proactive about asking for help, and I would really encourage you guys to do that as well. And then the last thing is that we here at MST, we are kind of equipped with the these types of situations, whether it be kind of advising you how to re-acknowledge your application, or things that you can do to improve like the strength of your application, such as your step 3. So if that at all interests you, definitely feel free to reach out to us.
I especially love the points, Roshan, that you made about reaching out to other people and kind of leaning into the individuals in your corner, whether they're friends, mentors, friends of friends. But that's, to me, I agree 100% that that's such a large component of this. And I can even recount stories of when I was a prelim intern, of colleagues who were able to find dermatology positions and kind of streamline into a PGY2 spot. And so that's, I think, a great testament to again, relying on the people that you have in your corner. All right. So as you're navigating your gap year, and working through trying to strengthen your application, of course, there's a lot of components that go into ERAS: clinical, research, volunteer, work experience, and with this time, you see it as an opportunity to really kind of flesh out those aspects of your story and build up your application. And so a lot of opportunities can exist in the clinical realm. You can volunteer as an EMT. There's scribe positions in a clinic, a local ER, continuing to observe positions, and again, building those kind of connections that you can utilize to help you find positions going forward. Volunteering with nonprofit organizations, some listed here. There's many, whatever advocacy group or charitable organization that kind of resonates with has a mission that resonates with you. And then also thinking about research and taking a step back. Again, this all kind of folds back to what Roshan was saying before. Like, think about what your weaknesses were in your application. Were there areas where you felt like, as you're putting together ERAS, you think, I wish I had a little bit more that I would be able to talk about here? This is your opportunity now to be able to do exactly that. And so, if there's certain areas of science, either basic science or clinical science, clinical research that speak to you, then look into opportunity to see what you can do there. Oftentimes, especially dermatology, I mean, I have the lens of dermatology, of course, but very commonly, many people do gap years before they apply. And so this is oftentimes very part and parcel with the process. And research fellowships are very, very common. And many people streamline into doing one of those for a year, before, even before they apply. And so that's another great opportunity for you to build up your application. Um, and then also talking about volunteer experience, again, this can be in a clinical context, but it doesn't have to be. I think there are a lot of great things that you can do, and it doesn't have to always just be for the sake of your application. Just it can be very rewarding and fulfilling to be giving back to your community. And then if you feel like you have areas of your application that you want to build up a little bit, for example, maybe your step 1 score, your step 2 score, then again you can use this time to really shine on step 3 and demonstrate a big delta, a lot of improvement, self-improvement in working through these board exams. You can pursue an additional degree, which can really make you stand out from the crowd, having an MPH, an MBA, a Master's of Science in some discipline. And then again, always thinking about your connections and the people that you're speaking with as you continue to foster these over the course of your gap year. You don't necessarily always have to use the exact same letters of recommendation that you utilized the first time around. And so this is another area where you might be able to build an even stronger relationship with a certain faculty member or someone who could write you an even stronger letter. So a lot of different things to think about of how to build your application and make it even stronger this next time around. All right, and with that, we'll shift gears. And so I'll let Roshan, if you want to take it away and talk about how to think about step 3.
Sure. And I think, we have a couple questions coming in. So I'm going to try to address a couple. Some I think are kind of specific, in which case I would really recommend you reach out to us. It really doesn't hurt to just send us an email, and sometimes we can just offer maybe a quick, insightful answer. But some of these, in these instances, it's hard to address on these specific questions. But there are some broader ones that I think can apply to a lot of the participants. But before I do that, I do want to say the thing you mentioned about reaching out to like a mentor. If you find that there was someone who you let them know, unfortunately, that you didn't match, and they were particularly disappointed, thinking that you were, I really, really felt like, you deserve to match. I saw your work ethic, your hard work. That's something that I would definitely agree with Mike. It's really important you maintain that relationship with that mentor. Whether that's, just, especially if it was in the field of your choice, which would be ideal, taking the time out to just, find a way to work with them. Sometimes these things don't always work if they're in a private practice situation versus an academic setting. But as long as you can stay in contact with them, they're going to see that determination and try to make that even more clear in their letter of recommendation. And often these doctors and these mentors are more than willing to adjust their letter of recommendation and say, despite this person not matching, I still see these qualities that would make a great applicant. We will try to address some of these questions towards the end, but two that I thought were particularly helpful was one, if like someone felt like their school was not necessarily supportive of the residents. And I think that's a very unfortunate situation, but one that I'll be honest, I have heard from other students, in which case, I think it's important, one person was questioning if they should email different program directors because they don't have this mentorship. I think it's important that if you don't feel the school is giving you support, finding your support elsewhere, whether that's here at MST where we can always be of help, or if it's colleagues or other people. If you feel that your school has not always been supportive, historically, there's probably other applicants who have felt that way, and that's where reaching out to someone who's now a PGY1, PGY2, who was in a similar situation, I think would be really helpful. But I think it's really important that you go about this with at least a plan in mind. So emailing the program directors, you at least want to have a very clear reason why you're emailing them. Just emailing them for the sake of being on their radar, I think can, at times not be constructive. I wouldn't say detrimental, but you want there to be a reason for everything that you're doing. And so that's where I think getting that help elsewhere can be really helpful. And I did see another question about, in particular, will, about a certain research aspect of how, will that be specific, helpful for my field. So they were describing doing oncology research and health informatics. Will that be useful for an internal medicine and family medicine residency? And I think in general, what a residency wants to know is not, they want you to be doing research in their subject matter, but they really are also very impressed by the fact that you know how to do research. Because I'll be honest, like, when I was starting to do research, I didn't really understand the process. I didn't understand a lot of the biostats, a lot of the nuances of what doing clinical research is. So by showing that you have any research, you're already ahead of the game. And I will say a lot of it, I think, is how you frame it. Once you get these interviews, how are you going to frame this research and say, this is what's going to, despite it being in maybe oncology or informatics, this is what will help me be a better internal medicine or family medicine doctor. Just going off the one example, but, in general, no one will ever fault you for doing more. No one will ever fault you for volunteering, doing research. And so it's just all about how you frame what the value of that is to you as a prospective resident. Now shifting gears, and like I said, we're getting a lot of questions, but we will definitely do our best to address them in the Q&A. But in regards to step 3, I would say that it's very important to prepare for this exam, especially if you want this to be something that shows a deviation in your application. Maybe your step 1 and step 2 were not great, and there's a lot of factors that can be contributing to that. I think for one, I didn't realize that there's a large disparity in dedicated study time that different schools offer. But here's the time for you to equalize that. If you find that you have more free time to study for your step 3, give yourself that ample time to prepare and really try to do your absolute best on it. Avoiding resource fatigue, I think now more than ever with step 3, as you keep going, you see more and more resources pop up, and having a stepwise approach to what are the resources I need, what am I going to use, and what is going to help me maximize my chance at a good score. And a couple specific things is that the CCS cases, I think, can intimidate people a lot. And frankly, personally, and I think a lot of other residents would echo this is one of the easier parts of step 3, but it's a big hump when it comes to, getting used to the whole software. And that's why we're going to try to go over that a little. But for the most part, the CCS cases, these are bread and butter cases you've probably seen personally. And the other last nuance is biostats. I feel like in step 3, you'll hear everyone say it. It truly is like a little bit extra on step 3. And I think that things like that, knowing that historically, step 1, there's going to be a little biostat. Step 2, so you strategically say, I'm not going to worry as much about this. I've never really gotten it. Step 3 is that time to say, okay, I really need to buckle down. I'll get the biostats package, but I will, learn these concepts because it does show up quite a lot on step 3.
Very true. The biostats point, especially the first day, your multiple choice is going to be a heavy preponderance of ethics and biostats. And so there's one thing you take away tonight about step 3. You have to know. And this is something whenever I'm working with students on this exam, this is something we emphasize over and over again, because I off the top of my head can't give you the percentage of the test that's biostats, but I would probably estimate it's well into like 10, 20, maybe even upwards of that percent. All right. So just a little bit about thinking about your timeline. I'm a big proponent in general for all of these tests to have a test date in mind. I think if you have an open-ended date where you might have a 3-month eligibility period, but you really haven't specified when exactly within that time frame you'll take it, to end up in a situation where there's not much of a sense of urgency to study, and you have other commitments that you're balancing and trying to carve out time in your day to devote to preparing for step 3, and if you don't have that motivation of here's the date when I'm going to take it, here's what I need to get done. So every day between now and then, this is the amount of things that I need to finish to get done with everything that I want to, if that makes sense. So having a test date in mind helps have a very concrete sense of what your timeline is going to look like and how much you need to get done each day to finish what you need to. And in line with that, you need to be realistic, because it's like all of these things, there's just so much that they could test you on. And at some point you have to draw the line of like, here are the resources that I'm going to be able to get through. It will not be every resource that's available to you. And so it's important to triage the things that are important. Things like focusing on the UWorld, practicing the CCS cases, and we'll talk a little bit more about that. I did not practice what I am now preaching about the 2 test days. I did them back to back, and if I could go back, I would have spaced them out. It's exhausting. The first day is a lot of multiple choice questions, and then you go home, you try to sleep. I mean, you should sleep, and then you wake up and you feel like you're doing it all over again. So avoid Groundhog Day and give yourself time in between. It doesn't have to be a lot. It shouldn't be a lot, but something like a weekend or a day or two, just to be able to recharge, get back into your rhythm, get another good night's sleep, and then dive in and take day 2. Roshan, did you do them back to back, or did you give yourself time off in between?
So I think, and I would recommend this to everyone. I did the weekend in between,
Yeah.
and I found that it was one of those things that it was helpful to my program. Like I wasn't like in one day, out the other day. So I think my program appreciated me taking it on Friday and Monday, and also like that weekend. I feel very strongly like the day before an exam, I don't like to study. I like to relax. So that weekend doesn't have to be a lost weekend. If you're going and taking it in your town, then have a nice day out in the town. If I had to, it was hard to find a test center near me. I was with my parents. I hung out with my parents for the weekend, and it was a great weekend. But having that break, I think, was so nice. Just like because I can definitely attest that first day is exhausting, and I had no desire to like go right back into it.
Absolutely, yeah. So I think we're both on the same page 100% that giving yourself some time off in between is very important. And then the last point on here is like anything, it's good to be able to you need to have that checking in process of here's where I stand. And the challenge is that as you advance through these board exams, there is less and less available to you in the form of practice tests. And so that's something that I often work with students on about how to incorporate that. Of course, have the 2 UWorld self-assessments. The NDMEs are there. I sometimes struggle with the quality of them and the predictability, but it is important to, especially doing those 2 practice tests from UWorld, to make sure you're incorporating that. So what do you typically recommend to students about your typical study schedule?
So, I think it's very important to, have in general any schedule, and I think Mike would definitely echo this. Whenever we work with students, the number one thing that's in the first session is let's get a schedule going. It keeps you honest and it helps you reach like attainable goals, not setting like a closed date for when you have to finish the test bank by, or just, saying, okay, I'm going to do this half, by during this block. No, I think if you set, you don't have to do day to day, but week to week goals. And I think it's a lot of it is just doing a good stepwise, ramp up. And you can do an extended study period. Don't get me wrong. This is just a sample schedule, but doing it something like getting a good amount of questions done. This schedule is something that I personally was very similar to my schedule, was doing a lot of UWorld questions early on and then sprinkling into cases. The cases are definitely just a different flavor. Once you get used to them, they go by pretty fast, but you want to get used to them, get the nuances and get the most out of the cases. And so week 3, maybe you would start doing the cases after you have, the UWorld questions has kind of refreshed your memory. And that's the other thing. These cases are kind of in every different field of medicine. Step 3, even if you're doing, pediatrics, you're going to see some OBGYN. If you're going to do internal medicine, you'll see some surgery. And so in those instances, it benefits you to have that refresher. So that's why I would not recommend the CCS cases off the bat. Even though they seem really scary because they're so foreign, you really do pick them up pretty early. Week 5, you finish up your UWorld questions. The other thing that's a nuance is that this is where I think you think about where you stand. Is your goal to get a good score? Is your goal, then maybe you're doing the incorrects. Is your goal that you need to pass and then make sure that on residency, during your prelim year, you're on point, you're hoping to get a categorical spot and you don't have as much time? That's perfectly reasonable. But as long as you have a plan of what your goal is for that score, that's how you can approach it. And then the other thing is just like, these small nuances of going through these high yield cases. And the last thing that I want to echo that Mike mentioned is the practice test. this is where I think that we can be very helpful, is knowing when to take the practice test. Because we personally have gone through this, and we've also worked with a lot of students. So we know, when a practice test is going to, give you insight about what your weaknesses are, when it could potentially psych you out. And we do take that all into account when we decide, how to set up a study schedule.
Absolutely. And so shifting gears then, kind of dovetailing off of what Roshan was saying about adding in the CCS cases, and just talking about those specifically now and how to incorporate them. The resources that are available to you, the two main ones are the UWorld Interactive CCS cases that come with your subscription to the software, and then a kind of unique a website that we'll talk a little bit more about that just gives you additional cases. The most important thing to me that I really communicate to students is you don't have to have perfect. The goal of the case is not to develop perfect management here. It's not like I need to memorize all of the tests that they ordered so that I can do the exact same thing if on the very remote chance that I get a similar case. The point is that you need to get that level of intuition will come with time and with practice and doing questions and doing these cases. The most important thing is getting comfortable with the software on many levels, because it's not truthfully particularly intuitive. It's in some way like a new EMR that you're trying to navigate. And then there's the added component of you really have two clocks that are happening at the same time. Cases can be anywhere from 10 to 20 minutes. And so that's the amount of time that you have in the interface, and it's counting down. And so that's your kind of case test clock. And then you also have a separate clock happening within the case, the timeline over which the case is playing out. So, you meet the patient at time 0, and then as you are ordering tests, these tests are coming back. As you are discharging the patient and having them follow up, or all of these kinds of nuances, time is elapsing, and you can see how the patient's care, their symptoms, their presentation evolves during that. So it's just a matter of getting used to those two different aspects. And there's a lot of really helpful resources on the USMLE website. They have they talk you through what all of these things that I'm describing mean. And then I think further moving into the next point there, and actually navigating the case with respect to how you're thinking about it. Oftentimes they're going to give you a lot of the classic presentations for some of these conditions, but you still want to have a differential diagnosis, because a pitfall that you can fall into is anchoring on a specific one, trying to see the case through to that ending, and the case just won't end, or the results are not coming back the way you want them to. And when that happens, then you have to take a step back and think about, what am I missing here? And if you do that up front and have a differential diagnosis for, this is how abdominal pain, these are the things that cause abdominal pain, these are the things that cause chest pain, these are the things that cause hematuria, then it can help you avoid ending up in that kind of situation. The next point is just kind of comes with medical training, but just having an idea of like vital sign abnormalities that make you think a patient might be a little bit sicker than they might be saying. There's also a lot of just easy points that you can pick up. And we'll talk about again, this is where the ccscases.com can shine. But if you think a patient's going to need surgery, make them NPO and make sure you have the pre-op labs. Those are easy points that can be very easily, that you might easily miss and not think about, but we'll go into the scoring of the case. Another great example that I have to emphasize over and over and over again is, if a patient could be pregnant, you really should order a pregnancy test, because it will inform the medications that are safe for that patient. It will inform the diagnostic tests that are safe for that patient. You really can't do much more until you know whether they're pregnant or not. So it's very, very important. If they could be pregnant, you have to check. And then the one area where you can really shine is counseling the patients at the end. And so make sure you take the time to if they are a smoker, make sure you counsel them to stop smoking. And there are other nuances like that we'll dive into, but these are great things to kind of jot down as you're going through the preliminary data in the case, just so that you don't forget it when you're doing your wrap up at the end. Roshan, did you use ccscases.com, or do you recommend it to students?
So I personally did not use it, but I do recommend it to students, especially some that find that the cases still are bothering them. I find the UWorld one very, I think they do, as always, UWorld just does a very good job of replicating what the exam software was like. And, I felt like the cases gave me enough variety to feel prepared. But, the caveat being that a lot of people really love this CCS case simulator. Like a lot of them swear by and say like the cases were so easy because, they just felt so comfortable with this website. How about you?
Yeah, absolutely. So I think the way that it really shines is the feedback that you get through the website. And specifically, it really helps you hone in like these are the things that I should be focusing on or paying attention to, like the counseling, like making patients NPO, like checking the pregnancy test. And there's many other lists. So on one hand, it's just the volume of additional cases that you're able to do. And on the other hand, it's because truthfully, the UWorld will not do that for you. The UWorld just kind of gives you a printout, like here are the things that we would have done, but it doesn't help you. It doesn't give you any interaction or feedback on what you did. And so I think that's one of the, now, whether or not that actually is bona fide of like how the USMLE grades your exam, I, I don't know. I'm a little circumspect, but it still tests you. It still helps you get an idea of the important things. And so I think it's really, if you guys want to give it a try, we are not affiliated with ccscases.com. We just like it because it works well. And so if you want to give it a try, they have a couple of free cases that you can steer, test drive. All right, let's dive into some practice cases. Roshan, I'll let you take it away with our first one here.
Sure, sure. So I'm just going to go ahead and start the case. So generally, like kind of how Mike mentioned, the format will be that they present you a case, and they want you to like kind of present your next steps. Now, in some ways, it seems like almost like so much further from what real experience is like. When you get an admission, are you doing all these things, or is it kind of just like a natural flow? But at the same time, I think that one thing the cases do get across is that at the end of the day, when you discharge a patient from the hospital, did you accomplish all these things? Did you rule out anything that could be especially emergent? Did you do things like counseling? And did you make sure that you were very comprehensive? So even if a diagnosis was slammed out at you, were you kind of aware and cognizant of what else could be going on? So in this case, we have a 23-year-old female who's presenting with right lower quadrant pain that started 3 hours ago. The pain initially began at her umbilicus and then later migrated to her right lower quadrant. It is also associated with nausea, vomiting, and chills. She has no significant past medical history aside from endorsing smoking, a half pack per day. So immediately, I think a lot of you are probably, as you guys are, you guys, I even see some people giving us a differential. And that's who you all are. You guys are medical graduates, and you're going to be thinking. So exactly that, we're getting some differentials already, but now more than the differential. So that's great. That's immediately what you want to be, what's going to be popping to your head. But in addition to that, now what are the nuances of getting the patient admitted? And then, as Mike mentioned, this is always really important, the smoking. Whenever you have a chance, and I would recommend this in real life too, in the ophtho clinic, we, occasionally I'll come across smokers. And one thing, I usually have to ask if someone has like macular degeneration. And I will say, like, if I'm able to, I always try to do the smoking counseling. It could save, it really can help, like, prolong someone's life. And in these cases, that's why they really, really want you to hone in on that. So you guys honed in on the right lower quadrant pain, the nausea, the vomiting, the chills. You have your differential. You have the timing. So what next would we need to do? We're going to probably, if we were admitting this patient, need to examine the patient. We can't rely on the history. We might get some labs, but there's a couple other things that, we might want to do as well. So I want you guys to take, 10 seconds, think about what else might be going on, and then we're going to continue. So, and this is while you guys are thinking, the big thing is that, like I mentioned, this is a straightforward case, but how are you going to make sure that they know you're, turning over every possible angle? And part of that is just understanding the software. How do you understand the software? You really just practice with it. In the beginning, it's frustrating because you're, like, this is so odd. But let me tell you, this is how residency is. When you, like Mike mentioned, like learning a new EMR, you really have to just kind of play around with it, try everything, and then give it your best shot. And eventually it becomes second nature. So what would we order? So we mentioned getting a physical exam. We mentioned getting labs. What labs are we going to order? Sure, you want a CBC. Sure, you want a CMP. We get those on everyone. But now, if you're thinking that this is a surgical emergency, now what else do you need to get? What does your surgery team, when you were a third year or fourth year, what did they always ask for? Oh, what's the patient's coags? Are they on any anticoagulants? There's all these little nuances that you might not, it might be second nature because the surgeons are reminding you. The other thing is, how are you even going to get the surgical team involved? Most of the time they're also being consulted, for instance, by the emergency department in the same situation. But here you are the emergency department. You are the triage doctor. So who else do you have to call? You have to call the surgery department if you think that this is potentially a surgical emergency. You're going to order some imaging potentially as well, right? So there's a lot of things that need to be, and what the software likes is that you present that all to them, not in a stepwise fashion. Like you get your labs, okay, next you want to present all as if like, okay, I need to get all of this done, and then the case will proceed.
That's a great point because on some level, there's going to be a little bit of time when you place the order to when the result comes back. And that cooking time you can have running in tandem. So if you wait for your labs to come back and then you order your imaging, then it's going to take your time, the waiting period for getting your imaging results is going to start at that exact moment when you order the imaging. And so if you feel like you already know that you want it, then you might as well order it. So you guys did a great job with this.
Yeah, you were. I felt like they really locked in.
Yeah.
This patient would be in good hands with them. But the other thing is, as Mike mentioned, and this is another thing that I think is a little bit of a nuance with the software, is that time is kind of elapsing. He mentioned two clocks. There's your case clock, and the case clock is interesting, and I'll discuss that in a second. But there's also a clock of the case, and so there's times when in real life too, you're waiting on results. But there's a part of the software, a nuance, where you're going to accelerate the time, as long as you think you've ordered everything and you're not missing anything, because you need the day to go on. And so that's another thing to get used to. At first you ordered this and you're like, okay, well, what's going on? Well, you have to get used to the software and say, okay, push forward until next available test result, or push forward until the next available, or 2 hours from now, and then you'll get everything from 2 hours, and you'll figure out, how you want to accelerate the time. But that's another component. Once again, something that we're more than happy to show you, but also something that can definitely be acquired by just running through these cases. A couple other things kind of in the labs. We mentioned, getting the coags, maybe getting a blood culture if there's fever, the physical exam. Unfortunately in real life, your tending is saying, I want, the full, point exam. But in these cases, they actually want a targeted approach. So you can't just inspect every body part. So you have to say, okay, what in this instance is pertinent to this patient? What, as much as I would love for them to get an eye exam, it's probably not appropriate in this instance. So you're just going to get, the heart, lungs, abdomen, general appearance. Very often there's like a common one that's why we call it the big four. You're almost always going to want to get those. And then you kind of target the other nuances of the exam for them. And then things like imaging, knowing that, for instance, like if this is appendicitis, you don't necessarily always want to get a CT, right? If the ultrasound, or for cholecystitis, if the ultrasound gives you the information, you're reducing the radiation burden on the patient, why not get the ultrasound? And then the last nuance is that pregnancy test. I saw a lot of differentials of ectopic pregnancy. That's great. And so how do you kind of rule that out? Simply a negative pregnancy test. And that's something they really, really want you to key in on. And if you'll notice in your clinical experience, this is almost like, every single ED doctor will really fixate on this. Why did the patient not get a pregnancy test? There's an indication to get it. So just keep that in mind.
Absolutely. Agreed 100%.
And, these last couple things, would you, and the things I purposely didn't mention, but would you remember to make the patient MPO? You're not, I personally did a preliminary medicine year. So I was used to people telling me, yeah, the patient MPO after midnight. But, now it's on you to remember, okay, I should make the patient MPO. I mentioned, consult the surgery team, but are you going to make sure, what are you going to do in the meantime? The surgeons aren't going to immediately fix the issue. patient needs, do they need antibiotics? Do they need like things, and simple things like IV access, like how are they going to get the meds? You have to say, there's an order to say insert IV. And if it's an outpatient, and then it can become such second habit that, oh yeah, always insert an IV. But if it's an outpatient case, that's not necessarily indicated for, the classic outpatient case is a UTI. In those instances, there's no reason to get an IV access. Things like pain medications, where sure, that's not necessarily threatening the patient's life, but as a doctor, it's not just your job to save their life. You need to make sure that they're comfortable, that they're both comfortable physically, but also mentally. And that's where things like counseling, not just on smoking cessation, but there's an option to, talk to the patient about the results, explain if in case they seem anxious. And all these are nuances to this test taking software that you kind of just have to get used to.
Absolutely. And I think one point I'd highlight here is if the patient is having a lot of symptoms, this is kind of low-hanging fruit. If they're nauseous, if they're in pain, you can give them a medication to help with that. So if they're vomiting a ton, you can give them some ondansetron. If they're having a lot of pain, and you can give them, not pending whether it's safe or not, you have to make sure that the medication they don't have any contraindications for it. But that can really help you score some low-hanging fruit points, because it's just good. I mean, generally good patient care if the patient's having a lot of symptoms. So don't forget the symptomatic treatment as well. All right. Well, great job, you guys, on that case. So we're going to do one other quick one. This one's a little bit more. This is an example case from one of the practice cases that we mentioned from the USMLE's website. Excuse me. And so as we work through this, I just really want to encourage you guys to chime in with what you think might be going on and how you might advance forward. And so once you open the next case, this is the text box that'll populate. A 65-year-old white man is brought to the emergency department because of sharp chest pain and respiratory distress. He is in acute distress, moaning and holding his hands over the right side of his chest. So I'll take a second and I'll let you guys kind of chime in about what you think might be going on. And while you're doing that, I'm just going to make a couple other comments. You see that this is your time 0. So it's 4 o'clock in the emergency department, and your day timer is going to move forward from that point while your test timer is going to count down. I think this one was maybe this one was 10 minutes. I can't remember off the top of my head. All right, great. I love it. People are already chiming in. Great. So thinking about ACS or an MI, good. A little bit different to be on the right side, but that's absolutely could be possible. Aortic dissection, I think that's great. Someone said pneumothorax. You guys are on it. This is great. I love the differential already. Keep it coming in. And so you advance forward and you get the initial vital signs. So he's afebrile, but he is tachycardic. And you really should have at this point kind of a intuition about normal and abnormal. So anything above 100 is going to be tachycardia. And then the respiratory rate, so 18 is typically the upper limit of normal. So he's really breathing fast, almost twice as fast as you might at rest. And he's a little bit hypotensive. So his systolic blood pressure is 90, his diastolic blood pressure is 60. And then here we have his height, weight, and BMI. So, as the data comes in, I'll let you guys keep kind of honing in on those differential diagnoses. If there are other things that you're thinking about, things that you're more suspicious for or less suspicious for. All right, I see ACS is still on people's radar. What do other people think? All right, dissection, all right. And then I'd say, this respiratory rate's pretty impressive. So maybe something pulmonary that you guys might be thinking about. PE, great, love it, awesome. Great, this is perfect. All right, so we'll advance forward. And so now we get the HPI. And so 65-year-old accountant brought by ambulance. He works at a trucking company. About 10 minutes before, he developed excruciating. So this is like very pointed language, excruciating sharp pain in the right side of his chest and marked respiratory distress. It's 8 on a 10-point scale. Increases with respiration. Does anyone know what's that called when you have chest pain that increases with pleuritic? You guys are so on it. That's great. So pleuritic chest pain, unable to answer questions. The patient has had emphysema and asthma for years and he's getting oxygen. And this is, I mean, when you're talking about, when we were mentioning before, having that idea of sick or not sick, this guy's sick. Like his vital signs, he's got a lot of vital sign abnormalities. He's got, um, he's not able to give a full history, frankly. And so that is telling that this patient is not well, and we need to do something quickly. And so now we're going to do the physical exam, and kind of honing back to what Roshan said before, you always want to have your big four. So you want to have the general appearance, you want to have your heart, your cardiovascular, your abdominal, and your pulmonary exam. And then from there, there are other nuances of neuro, skin, lymph node, HENT. I think these are generally always going to be included. Things like breast, rectal, genital exams, those you can kind of titrate on a case-by-case basis. If they have some reason that you need to examine those, then that would be indicated. But doing it as a uniform kind of thing for every single case would not necessarily be correct. So there is a lot of language here, and that's one of the challenges as you're working through these physical exams. Is they're going to give you everything: normal, pertinent positives, pertinent negatives, and then just everything in between. And they can drop some hidden buzzwords in here. Great, you guys are already picking up on it. You can drop some hidden buzzwords in here that that you have to find. So let's start with our big four. Let's focus there. He's well developed, overweight, appears in marked respiratory distress. We kind of already knew that. Moaning and holding hands over the right side of his chest. Okay, so not a whole lot more that we got from that. And then let's go down to his chest and lung exam, because that's the next part of our big four. And great, you guys are picking up on that. So no breath sounds on the right, but breath sounds are present on the left, and he has hyperresonance to percussion. All right, so these are, it's been a while since maybe you might have heard these words, but hopefully they trigger like, okay, this is trying to tell me something. So no breath sounds on the right with hyperresonance. I'll let you guys kind of, people are already chiming in with the right answer there. So that makes me think about a pneumothorax, exactly. And so again, we want to keep that differential diagnosis, but as we work through it, we're starting to get a little bit more refined in how we're thinking about it. He has tachycardia. He has weak peripheral pulses. He has a jugular venous distension. And so all of that's concerning. And then let's see. Let's finish out our big four with the abdominal exam. Pretty unremarkable. And then, I'll give you guys the opportunity to, hopefully you've had the opportunity to read through these, but there's one other area that I want to highlight that is pretty hidden but important, is in the HENT exam. You see slight tracheal deviation to the left. And so that's important, okay? So a lot to unpack there. And granted, our day timer is not moving forward as we process this. We're still at 4 o'clock, but our test timer is counting down. So we do have to maintain some kind of pace through it, but we took away a lot from this. This was time well spent because there was a lot of good information here. All right. So I kind of dived in, and when I was running through this case, and I felt confident enough calling this attention pneumothorax based on the tracheal deviation and the physical exam findings consistent with it to kick off the kind of workup that you think about for that. I also, though, think it's important that you maintain that broad differential. So other things that you might think about for the overall constellation is, is this ACS? Is this a PE? Is this something else cardiopulmonary that's going on? So still getting that CBC with diff, that comprehensive metabolic panel. And then I chose to get tropes and a BNP. He is uncomfortable. I think it's worthwhile to keep the oxygen in. And then the management is going to be a needle thoracostomy. And so that's where the kind of phrase that had been kind of beaten into my head when I was a medical student is a needle thoracostomy in the second intercostal space in the mid-clavicular line. And so that's something that's important. And then tube thoracostomy is our chest tube placement. The point is that it takes a long time to get a chest tube, and this is a life-threatening emergency. And so you need to do something quickly to help stabilize them before, while you're waiting for the chest tube. And then I'm going to get my consultants on board now. I feel like this is urgent enough that, I want thoracic surgery to come in and put the chest tube. I want pulmonary medicine on board in case I need any help with the pneumothorax management. So once you go through that, they'll give you kind of like a blurb that says, like, you did the needle thoracostomy and there was a big whoosh of air as it came out. And then, you ultimately place the chest tube. You have to get a chest x-ray So I did not get a chest x-ray beforehand. And that was deliberate because this is, again, a life-threatening emergency, and imaging should never hold up things that are life-threatening. If someone is hemodynamically unstable, you do not get the CT. If someone has a tension pneumothorax, you do not get a chest x-ray. In a perfect world, we wouldn't even know what a tension pneumo looks like on chest x-ray because it would never have existed. In reality, of course, the chest x-ray is portable. We can like quickly take it, and then we can do our thing. But on this exam, you get the chest x-ray afterwards, not to confirm the diagnosis, but just to make sure your chest tube is in the right place. And then don't forget that counseling. So you wrote down that he was a smoker and he has asthma and all of these things. So he needs to stop smoking. So you need to counsel him about smoking cessation. And so just some kind of takeaways from this is that make sure you read the history physical exam. I have a very short attention span, I'll openly admit. And so when I get that big block of text, I have to sit down and really tell myself, all right, I'm going to focus on this. I'm going to read through it, because you can miss stuff. You can miss the diagnosis entirely if you don't see the relevant pertinent positives in that exam. Do not delay care with tests that you don't necessarily need or ordering them too late, and provide treatment quickly. So if they have symptomatic needs, then supply those. If they have something life-threatening, then you need to move quickly, okay? If you guys have any questions about that, feel free to drop those in the chat, and we're happy to address those. And questions about navigating the CCS cases, but also just about the management of intention pneumo or about our first case. All right, so I'll stop talking for a second, Rachel. I'll turn it back over to you, and any pointers that you have specifically about the cases otherwise.
Yeah, so I think the two things that I definitely want to just really echo what you were saying is, the first is really reading through the case. I think is like kind of med students and veteran test takers, you get so used to looking for those buzzwords. And frankly, we get really good at it. You just get so used to saying like, okay, this is like, I see this, I see this, I see this. This is my pathology. Okay, what are they asking? Is it a direct question? Okay, it's not a direct question. Next. And like you think, I'm speaking faster because I feel like that's how my brain works. I can try to like instantly come up with these associations because that's, frankly, what the tests care about. But here, I think it's really important to go through the whole case. They'll sprinkle in that this patient is a smoker. They'll sprinkle in that, this patient, may not have a safe place to go back home to. Maybe they don't, they said like a patient was found on the street. So then in addition, you may need to consult social work to help with their placement. So there's a couple nuances in terms of making sure that you look through the whole case. And the last thing is, as I mentioned, as you mentioned, you can't necessarily do, even in real life, if like, okay, we always get the chest X-ray, we always get the CT, but you have to think about it how they want you. They want you to be trained as doctors, not just in our current climate, but, to be a doctor in any situation. So that's why they want you to be able to, recognize if something is emergent. Okay, like for instance, a classic example would be, if someone needs an exploratory laparotomy, okay, they have all the signs, they have rebound, they have guarding, extreme pain. You're not in real life, on the way to the OR, maybe you're getting the abdominal x-ray, seeing if there's air in the abdomen. But in this case, they just want you to immediately go for surgery, and so there's all these like nuances of knowing, and a lot of times it's really helpful to use your real life insight, but in this instance, you really need to know how the cases work. And I thought you did a really good a really good job showing that exactly in the second case. A couple other things is, even hospital have like slightly different ways they go about doing things, how they go about calling consultants. Like, my old hospital, it's such a nuance, but like, consultants used to put in orders. Then when I got to my current hospital, consultants never put in orders. You give your recommendations. So there's always like little things that you have to get used to. And so just because it's done that way at your hospital, it doesn't mean that it's done that way. So just knowing that there is kind of a universal standard they're looking for, and getting used to that. Doing every practice case, I really think that it would be a disservice not to do them. Because if you want to do well in this exam, you want to be as prepared as possible, do every case. Sometimes they feel repetitive. Sometimes they feel like, I really feel like I know exactly what to do. just do it. It takes a couple minutes. And if there's a new one, if you even just learn one thing, it would probably have been worth it. Um, the other thing is that there's a nuance where if you do everything right, the case can finish early. So that's another thing to keep in mind, is that, like, if you're doing well in these cases, you'll know sometimes, because they'll say, okay, if you for sure have not missed anything, the case will finish like with, like, a whole 5 minutes to spare, and you're saying, okay, yeah, I got that right. So just try to make sure that you maximize every single case. And just a reminder about spacing out that exam day. The cases that, they're not necessarily difficult, but it's just a new way of thinking. It would be nice to get like a nice 2 day breather. I definitely recommended it. I definitely would recommend it, and I personally found it very helpful. And just something, give yourself that break, so you can do as well as you possibly can.
Absolutely. And I think the point you brought up about the case may close out early, and that's okay. That's not a bad thing. And in many cases, it's a good thing. That tension pneumo case, for example, once you order that second chest X-ray, or once you order the chest tube chest X-ray, then it closes out the case because you've done the management. The patient has been taken care of. So common mistakes to avoid in general for thinking about step 3 is, I honestly, I think when I'm working with people, I sound like a broken record, but I'm just such a fan of questions. And especially, the UWorld is, for all of these tests, going to be your go-to resource. So make sure you're making at least one pass through there. Again, be realistic with your timeline, making sure that you can get through what you need to. And then generally my kind of spiel is always triage things you don't feel comfortable with. So, if you feel like you've just been avoiding neuro because you've just never liked neuro, that's an area of opportunity. Those are questions that you can focus on, pick up, and really shine on the exam and turn things around. Especially if those areas are things that you like, things like biostats or ethics. Those are very, very important areas of content, especially on day one, and you have to feel comfortable with them. It's absolutely a requirement. And then I am not a big fan of pushing tests back as a blanket policy, because especially if it's motivated by just a concern about it and whether or not you'll reach the score you want, you can end up in this cycle where you're constantly moving the test back and you're kicking the can down the road. And then it's almost like you don't have that concrete test date. You're kind of leaving it open-ended. And so when I'm working with people and we're trying to figure out what's the best timeline, is it realistic to take the exam when we want, as long as you have very, very concrete reasons of why you're moving it, and a very specific plan about what you will do with the new time that you have, those are the 2 criteria that for me you have to fill to convince me that it's a good idea to move your exam. And so again, applies for all of these, but also step 3. And so with that, Roshan, I'll let you wrap up tonight with a little bit more about MST.
Yeah, sure. So, really quickly, both, me and Mike are members of MST, but we're just a small group out of like a much larger body. And so, you can already tell that even, me and Mike were in different fields. We probably approach our studying differently. And the one thing I think that's really special about MSTs, they do a really good job of going out of their way to match you with the best tutor for you. Maybe Mike's a little bit nicer. Maybe he can give you those breaks that you need. Maybe I'm a little bit more, you really got to do this. And maybe you know what type of tutor you need at this point, or maybe MST will help you find that. But the big thing is that it's not just, the tutor that you're getting. You're getting these study schedules that we're kind of refining every time we have a student. We're trying to figure out ways to improve the study schedules. We do a really good job of communicating with you, not just during the sessions, but in between, emailing to check up. Have you been able to get this done? How have you, you suddenly got called for a Jeopardy week. How can we adjust your schedule? And it's not just, it's not just a one size fits all. So sometimes you're interested in tutoring for specific content areas. Sometimes you're looking for just insight about ERAS, or, a one-time session even, where, you're thinking, what with my body of work can I improve on? What should I be looking at? That's something that we're more than happy to help you with. So before we start into the Q&A, I think it's just really important that if you find things like this webinar helpful, at least, feel free to give us a shot, do a trial session and see where it can take you. And even if, you find that tutoring isn't necessarily something you're interested in, always reach out to us. We really do care about you guys succeeding and will try to help in almost any way that we can.
Absolutely. I'd second all of that. We're in your corner throughout the whole process and happy to tailor our experiences to help, you leverage our experiences to help you reach your goals. And so with that, we'll move into the Q&A session. So you guys have already chimed in. We've done our best to answer a decent chunk of these in real time, but I think a couple have come in, and please keep the questions coming. These are great questions. So someone asked about the free 120 for step 3. So this is on the website for all of these exams. There's a collection of questions that are, I think, retired from previous tests. And I'm a big fan. I honestly, the more questions you can do, the better. And especially questions that are written by the test writers. Those are going to be far and above very, very high yield. And so definitely would advocate if you're able to fit that into your study schedule. It's very, very worthwhile.
There's a question about looking for research opportunities or waiting to see if you can grab a residency position. And I think that's tough. And I really understand that, that it's you don't want to necessarily commit to the research, but there's still a chance you'll be able to get a position. I think it doesn't hurt to reach out and explain exactly where you're at. Say that, you're very interested in research. You're very interested in this. You have some other things going on in terms of, some potential options with residency. However, it doesn't hurt to reach out. It doesn't hurt to at least make them aware that you're interested. And I think, a little bit of honesty goes a long way. I think the one thing that I've noticed that, most people, they understand that this is a tough situation. So if you can't necessarily, you inquired about a research project and you can't join, that's one thing. But I think it's very, the only time that you can make a mistake is if you commit to something just with the hopes of acquiring that position and then reneging on that commitment. And it may not, harm your residency chances, but it's a door that you now just closed. So I think it's very important to, reach out, be honest, and say, this is my situation. And I think for the most part, people are very understanding of that.
A couple of good questions have come in about reviewing content from step 1 and step 2 as you prepare for step 3. And that's a great question and something that I go back and forth on a lot. So I find that if you feel like there are big gaps in knowledge from those tests, step 3 is going to incorporate a lot of those questions, especially day 2 is going to look a lot like step 2 CK. And you're going to get some degree of questions that are very step 1 like. There's going to be path images. I always, for whatever reason, for my exam, there was a lot of derm path. And I found that actually as feedback that a lot of people have given me. And I maybe it's just because I do, I think about derm path a lot, but like that's a perfect example of looking at, like you still have to have a degree of comfort with looking at a path slide and figuring out what you're looking at, which is very step 1 kind of exercise, but no yield certainly for step 3. So the short answer to the question is there are times where I have told, not infrequently actually, maybe half of the time I advocate for people, if they have the ability in their study schedule to incorporate components of previous UWorld to maybe fill in some gaps that they might have forgotten between when they took those exams and now. Let's see. A lot of really great questions are continuing to come in.
Yeah, there's a question about potentially delaying graduation to keep a U.S. senior status. And, I'll be completely honest, but I think this is one example where personally it's a little bit out of my expertise at MST, but one where I'm sure we could probably find someone with at least some insight. I think it's important that with any of these things is that you at least try to at least discuss with someone before relying on, it looks like, some people are mentioning that like that was recommended through Reddit or other internet sources, maybe like Student Doctor. I think it's important that at least you discuss this with, in a perfect world, your school's residency advisor, but at least someone who personally has gone through the that pathway, just so you know exactly what you're going into. So the big thing I think is, if we're not as necessarily able to help me and Mike, maybe there is someone here that at MST that can. But make sure you don't necessarily jump into a decision without knowing exactly what that entails.
One last question that we can address tonight is the the Find a Resident resource that we had mentioned before. I think it does present PGY1 positions. I think you have to go on the, they may or may not be listed depending on the availability, but I think it is going on the website. I think will give you more information. The other question that came up is about balancing reapplying for the new cycle versus thinking about finding a position now. And that's a great question. And what I would say is that as truthfully as time goes on from the match, there's going to be less and less likelihood of being able to find a position post match now. And so what I would probably advocate at this point is I would draw I would draw like a line in the sand of, by the end of this month, going into next month, if you're not having a lot of success with this round, then that would be kind of the threshold to um, look into getting ready for the next cycle. Roshan, any thoughts about that?
Yeah, I mean, I would definitely echo what you were saying. It's tough because in a perfect world, I know that all of you have worked so hard to get to this point, and you want to start that next step, that PGY1 step. And I think it's important that you don't, you exhaust all your options, but at the same time, just because you went unmatched this year does not necessarily mean that you will go unmatched. Maybe you have a preliminary position, maybe you don't. Maybe you're kind of looking for a way to spend a year, but I think there's always a good possibility, if you can figure out what your weakness is, if you can figure out what that nuance in your application is, to reapply and have a very good shot at reapplying. And I think that there is going to be a time when you need to focus on that, because as we mentioned in the previous slides, there's a lot of things that you can potentially be doing to improve, and those take time. Not just steps 3 studying, but all the also volunteer research. So I like what you mentioned about like specifically saying, okay, after this date, I'm now committed to the whole reapplication process.
Right, exactly. All right, guys. Well, thank you so much for tuning in tonight. There may be a couple of questions that we weren't able to get to, but again, we have our contact information here. Feel free to reach out at any point to our email address. Our website is listed here, and then, of course, our phone number. Just generally, thanks for spending your evening with us. We hope this was helpful. And again, feel free to reach out with any questions or concerns. All right.
Yeah. Good luck with everything, guys.
Good night, everyone.